Hi everyone, my name is Alexandria. We're going to go ahead and get started. A couple of notes about Zoom. So right now we have everyone muted and we'll continue to have everyone muted during the first part of this hour. Once we get to the questions section later on in today's conversation, you will be able to unmute to ask questions during the live Q&A. Another note is while we would love to see your faces, feel free to keep your video on or off. Just do whatever makes you feel most comfortable. So our topic today is disparities in healthcare access for the LGBTQ plus community. And we're so excited to be learning this afternoon from three incredible speakers. We have Hunter, Program Coordinator at the LGBTQ plus Center of Durham, Dr. Dane Wicker, Director of Gender and Sexual Diversity Initiatives in the Office of Diversity and Inclusion for the Duke School of Medicine, and Simone, a Duke University undergrad student and author of the blog that inspired this conversation, Listening and Learning, Part 3, One Size Does Not Fit All. I'm going to hand it over to Ashley now for some more introductions, and thank you for joining us.
Hi everyone, my name is Ashley. I am one of your moderators today, along with Alexandria DuPont. We both work at the Duke University Center for Global Women's Health Technologies. She is our Associate Director of Operations, and I am our Communications Specialist. So I'm just going to take a quick moment here to kind of introduce our center that's hosting this panel, let you guys know about what we do. We were founded in 2013 by Dr. Nimi Romanjam, and we work to create technologies that help women and advance women in STEM fields. So while most of the people at our center are engineering or medical related people, Alexandria and I have the opportunity to work on the educational part of our mission a little bit more through things like these panels. So over the summer, we created a blog series that addresses inequities in women's health. This spanned from the dark origins of gynecology to hard-hitting research kind of pieces to more personal experience stories. It was a great blog series, and that blog series has become this panel series. So without further ado, I'm going to pass it off to Simone, who, as Alexandria mentioned, was the author of one of those blogs that inspired this panel today. And before I pass it off to Simone, I just want to suggest that you put your Zoom in speaker view, and that way you can, just hear from the speaker, less distractions going on. So I'll hand it over to Simone.
Thank you. Good afternoon, everyone. Thank you all so much for being here, and thank you for that introduction. As was mentioned, my name is Simone Neighbors, and my pronouns are she, her, hers. I'm a sophomore Robertson Scholar here at Duke University, where I'm studying neuroscience with minors in chemistry and photography, all on the pre-health track. I know that seems like a bit of an interesting combination, but it's actually one of the things that I'm going to be talking about today. So I personally have a number of passions, one of which is healthcare equality and really breaking down the barriers to healthcare, specifically for the queer community and also for people of color, and even more specifically for queer people of color. Another one of my passions is storytelling, and I wholeheartedly believe that it is a vital component in everything that we do. In every job, every personal pursuit, really every corner of our lives, storytelling is how we impact the world around us. And so storytelling can look like a number of different things, but for me personally, it comes through photography, as I mentioned before, and also writing. And my writing is actually how I got to be here today. As was mentioned earlier, over the summer, I wrote a piece called One Size Does Not Fit All. And I challenged this idea of one size fits all medicine and really a lot of the dangers that come with that mindset. And I actually enjoyed that process so much that I started writing for a medical ethics journal here on campus, where I primarily focus on issues faced by the queer community when it comes to medicine and access to care. And so it really allows me to combine multiple of my passions in order to support a cause that's really important to me. Now, I know you're probably thinking, okay, why has she gone on and on about storytelling and how is that even relevant? But I promise it will all make sense in just a second. I'm also going to be completely honest with you that I was pretty nervous coming into this today. I spent a lot of time thinking about what I wanted to say and what I really wanted my impact to be. It can definitely be a little intimidating to come into a room and talk about healthcare disparities to a group of people, many of whom have maybe gone to med school or have a degree in public health or have worked or studied this in some sort of formal way. But So I sat down with myself and I thought, okay, what can I bring to the table and what can I leave people with? And I ultimately came to this idea that I think many of us were taught, but many of us have also forgotten. And that idea is that words matter. I'll give you an example of this. Last year, I was on a project team that we were working on various issues regarding cervical health. And I very quickly realized that the term cervical health and women's health were used pretty interchangeably. Now, a person I was probably a few years ago probably wouldn't have said anything about this. I probably would have swept it under the rug as to not rock the boat. But that's not the person who I was last year, and so that's not what happened. As someone who's learned firsthand the impact of our words, I knew that the only option was for me to say something, and so that's what I did. I sat down with my team and we had a conversation about how the terms cervical health and women's health weren't synonymous because A, not all women have a cervix, and B, not all people who have a cervix are women. And the response from my team was overwhelmingly positive. There was no hostility or annoyance or anything like that. The main response was, wow, I hadn't even considered that before. And see, that's the thing. There was no malicious intent or anything like that, but sometimes we all need a push to be challenged to consider the true impact of our words. Another example of this, and one that actually surprised me in the moment, but makes a lot more sense in hindsight, came from the same project. We were talking about various barriers to care and different things that might be preventing someone from seeking care, even if it was hypothetically available to them. And so, since I was focusing a majority of my project on the queer community, and I was still very focused on the power of our words and really the impact behind them. So I sat down and I said, I bet there's something in what we're saying that's possibly serving as some sort of unintentional barrier. And so I dug and I dug, trying to figure out what that could possibly be, what could possibly be amiss. And I actually came upon it by accident. See, I was proofreading a write up that I had just done, and I realized that I was saying sexual and reproductive health a lot. Now, as a writer, it's always pretty important to avoid being overly repetitive, but it's also pretty easy to go in, make a couple of changes, and call it a day. And so that's what I did. But I very quickly realized that it wasn't just that piece, it was every piece. It was every presentation and every conversation. It was simply ingrained into our vocabulary. And so right now, the issue with saying sexual and reproductive health probably isn't too clear. And it honestly wasn't to us either at the time. And so this isn't to say that there aren't times when saying sexual and reproductive health isn't the completely accurate terminology, because there are definitely cases when that's true. But in our case, we are really mainly talking about sexual health. We added the reproductive partially for our own comfort, but also partially because we had this idea that by including more words, we were covering more bases and therefore being more inclusive. But in reality, this is not what was happening. In fact, I realized that by saying sexual and reproductive health, we were actually alienating a portion of the queer community. So for people who maybe weren't thinking about reproduction, or that wasn't really something that they saw for themselves, I was giving them an out to say, oh, this isn't actually something that concerns me, and this isn't something that I need to pay attention to, when in reality, that was not the case. And so really just those two extra words made a world of a difference. Now, I bring up these points and these seemingly small details, not to be nitpicky or to scare you into silence. In fact, I want to do the exact opposite. Just by being here today, you're all showing that you care about healthcare equality for the queer community, and you're willing to put in the work to see a change. And so I want to challenge each and every one of you to keep having the conversations that you're having. Have more of them, have them differently. Continue to challenge yourself and your thinking. And don't be afraid to speak up if you notice that maybe the impact of someone's words isn't quite matching the intention that was behind them. And so if you're going to remember anything from these past few minutes, please remember this. Remember that words matter. Thank you.
Thank you so much, Simone. We're looking forward to hearing more about what you shared when we get to our Q&A section in a little bit. I'm going to go ahead and pass it over to Hunter now to share about their experiences.
Hi, everyone. So my name is Hunter. I use pronouns they, them. I'll also accept she, her, but I prefer if you didn't. Thank you. I'm the LGBTQ I'm the program coordinator at the LGBTQ Center of Durham. I'm also a public health professional, a photographer, a writer, et cetera, because as Simone mentioned, we all have a bunch of hats that we're usually demonstrating our many skills and talents. My intention with talking to y'all today is to not only discuss access issues when it comes to access to care from a public health perspective, but also how my own experiences during COVID have pretty much been kind of like interwoven into a lot of this. So I'm dealing with not only professional expertise, but lived experience. So to kind of preface it with just some details, I wrote a couple things down because otherwise I will just go off on a tangent. The important discussion point in all of this is that I want folks to be an accomplice and not just always an ally. And by that, I mean, great, we have a lot of allies. We have people that are readily willing to put that label on themselves of, oh, I'm an ally. But really the definition when it comes to ally is someone that is commiserating or somebody that is empathizing with your misery. Whereas we need a lot more, and especially in the healthcare field, we need a lot more people who are our accomplices or people who are willing to take risks and to stick their neck out on behalf of others who do not have that privilege and may also be marginalized. And so I want to see more of that coming through when it comes into all playing fields, and especially in the healthcare system, where frequently we are, and LGBTQ plus folk are traumatized and often mistrusting of the system. And so there needs to be a lot of work on there. So Durham's LGBTQ plus population, we have the second largest concentration of same-sex households, but I prefer to use LGBTQ plus households across all counties in the state, and we're the 42nd highest concentration nationwide. There's a lot of intersections when it comes to LGBTQ plus identity, including, but not limited to, folks with disability, undocumented folks, poor people, people living in poverty, people of color, genderless identity, gender identity, and or presentation. And all these things add to multiple layers of marginalization, which further disproportionately affect this population. So when it comes to access to care, we are frequently traumatized by those experiences that we may have had previously, or we may have never had those experiences because of a lack of, we don't have the means to make that possible. Regarding that access to care, those that were uninsured listed costs, including copays, employer, and immigration status as their three primary reasons of not having access to care. And when we're talking about a lot of this, I need to make sure that I mention that transgender folks, especially trans people of color, are one of the most discriminated against groups within our society, and especially within the healthcare facilities and healthcare industry. And so that is one of the things, that's one of the things that we really need to make sure that we're aware of, and that we also need to be pushing forward when we're helping to change a lot of these issues within the healthcare industry. So there's a lot of, various disparities, including economic, mental, infectious disease, chronic disease, and access to healthcare. And a lot of our personal bias or stigmas that we may internalize come from outside sources. And maybe we, and by we, I mean LGBTQ plus community. A lot of times there's a lot of experiences that may lend to us not wanting to seek out help, or seeking out help once once we're having a concern that's quite exacerbated. And so from my personal experience, during COVID, I recently started to fall ill with my own autoimmune illness, and I was tossed around in the medical side of healthcare quite a bit and treated rather poorly. And so when I go into those situations, I frequently feel like, am I going to be discriminated against because I'm Black? Am I going to be discriminated against because I'm non-binary, because I'm queer, because I'm femme, because I'm fat? And, there's a lot of questions that come with that. And so I've noticed that even when I go into a lot of these appointments, that I frequently will dress more femme, or I will try to speak with a higher pitched voice. And, it can be quite traumatizing for some people. And I know for me that having those, it's scary, because not only do you not want to be there, you're also afraid to face individuals who may have a bias against you, or may not want to treat you because of the way they present yourself. And I definitely have experienced that as well. And so the message, I guess one of the overarching messages that I want folks, especially going to be entering into the healthcare industry, is that healthcare is something that is it's a basic human right, and that it shouldn't be a form of elitism. And that's a lot of what we're treating it right now. And this is something that is, you're going to have to do the work. You can't ask someone, what do you need? Because sometimes we don't know how to articulate what we need because we're not treated with that dignity.
Thank you so much, Hunter, for those really valuable insights and for, sharing your personal experience. We really appreciate that. So if you have any questions for Hunter, keep them in your mind. I'm going to pass things over now to Dr. Wicker, our third and final speaker, before we move into our Q&A portion.
Hi, I'm Dane Wicker. My pronouns are he, him, his. And I just first want to acknowledge Simone and Hunter's contributions and really powerful words. I will speak, so I have a number of different roles at Duke, including, and I'm a clinical psychologist by training. And my focus has been on healthcare for LGBTQ plus individuals, and particularly transgender folk who are seeking medical transition, and non-binary people who are seeking medical transition, and trying to help kind of these navigate hoops through insurance, and how can we say things to get people the coverage and the care that they need, which is really quite a challenge. So yeah, I think that we've seen a lot of health disparities, some of which Hunter already mentioned with the pandemic. And I think that what is important to think about is that these are disparities that were already existing. They were exacerbated by the pandemic. And whether that's people losing their jobs and losing a source of income, losing their health insurance, it's also related to the political climate. And one story, so in my clinical work, I, especially with kids for puberty suppression, I'd have the North Carolina state statute of anti-bullying printed out if there was bullying at school. And the sad part to me was talking to children who were so jaded at such a young age that they would not be able to have be protected in their schools, or even in healthcare settings, that it was crippling anxiety, really, in a lot of cases. And so one of the problems has been that, how do you keep, I would print that off and say, well, even at the very worst, if we're just assuming the worst, that your principal doesn't care, they probably don't want to get sued, and would be able to kind of show them the statute and say, so there was some, and I think that would usually provided some comfort, even though it's coming from kind of a very jaded place for kids who are so young. I also work with adults as well, but I think that that is one of like the moments that really struck me. And I think that the health system is trying to improve in many ways, and sometimes it feels like 2 steps forward and 4 steps back, and it's a constant effort to really make Duke the most inclusive place that it can be. And we also want to acknowledge the intersectionality of people's identities. And I think that people, I think that there are some topics that are not discussed that need to be discussed more, like more and more people since COVID having to get hormone replacement therapy, not from physicians, but it's out in the streets. There's hopefully it's coming from a nurse, but oftentimes it may not be. And so there are a lot of these health risks that have come up with the pandemic that are really problematic. And then at the same time, I think when Hunter used the word elitism, and I think that one of the things that we look for, or insurance companies are looking for, is a history of medical compliance and getting hormone replacement therapy and seeing a therapist, all things which cost a lot of money, like the transgender tax is what some people call. And so I think about that, and it's I think that elitism, healthcare elitism, is a very probably accurate way to put that. And a lot of my efforts are focused on more structural changes now, because I was feeling frustrated that, and just working with patients, it almost felt like kind of in a hamster wheel that we couldn't get out of. So a lot of what I really want is to make lasting change at our institution, and really to engage our community members is the other piece that I think that I think that we can do better at Duke, and really listening to the voices that we have here. And so that's what I wanted to say. I'm hopeful about the future. There are a lot of initiatives coming out from the health system, and I'm hopeful that we can have a conversation about what else is needed and advocate for that. Thank you for letting me talk.
So right now we're going to move into a Q&A portion of our conversation. Thank you so much to all 3 of our speakers for sharing about your experiences and the work that you all are doing individually to make some changes. So we're going to start off with a couple of questions that people sent in through the RSVP form. And our first question that we'll get started with is a question for Simone.
I also just want to add really quickly, while we're going through these questions that were sent in through the RSVP form, which thank you so much if you submitted a question, be thinking about questions you might want to ask, and you can, after we get through these couple pre-prepared questions, we'll use the hand raising feature to call on people. So if your question isn't in these first 3, it doesn't mean we won't get to you. It's coming, I promise. So yes, this first question is for Simone. If a patient reveals that they identify as LGBTQ+, what specific actions do healthcare professionals need to take in order to meet their needs?
So I want to preface my answer by saying, I'm obviously an undergraduate student. I don't really have clinical experience, so keep that in mind. But I also think one of the most important things is kind of goes back to what I was talking about before with the one-size-fits-all approach, is that it honestly can't work for everyone. So like there isn't a handbook to say, okay, these are the exact 3 things that you need to do and it'll all work out. And so I think really the most important thing, something that you would think would kind of be common sense or a given, but unfortunately it isn't, is to treat people with respect and kindness. And so that maybe means respecting someone's pronouns or their name or their presentation. So first and foremost, respect. And then I think an additional thing is really being aware of your own biases and your own assumptions that you might be bringing to the table and doing your best to steer away from them. And so even if the biases aren't inherently negative, they are still, by trying to put someone into a box of what you think the situation might be, that can actually end up harming someone, even if that's completely not your intention. So be respectful, and try to avoid assumptions. And then also lastly, just something small that I know personally has been very helpful is to maybe add something to kind of show that you are supportive of the queer community. So if that's like something as small as like a headband or like a clip on your ID or whatever it is, even those small differences can make people feel much more comfortable coming into the situation. And so those are kind of my general things that I think would be really helpful for working with patients who identify as LGBTQ+.
Thanks, Simone. I think that was really helpful. The next question is for Hunter. This question, they gave a little background of noting how LGBTQ+ individuals are more likely to get ejected from their homes due to their sexual orientation, and some may end up unhoused. So the question is, how do LGBTQ+ people experiencing homelessness obtain quality health care? How can we, as future providers, make our services more available to LGBTQ+ individuals, especially those experiencing homelessness?
Well, so this is a multi-tiered question, and I'm gonna be a little bit of a stats geek right now because that's my background. There is a concept known as counterfactual dependence. And basically that means that with every solution that you have, there's gonna be 10 or so problems behind it that are gonna come up as a result. And so when we're looking at means of healthcare, that's when you're looking at it as like, this is the priority. We need to get them healthcare without looking at anything else. For a housing insecure, housing unstable person, that's elitism at work. What you need to be thinking is, how can we meet this person at this point in their life or at this point in their trauma to help bridge that gap so that we can ask the questions to get them that healthcare that they need. And so in a lot of ways, you're going to be treating folks from a baseline. You're going to be communicating with people from a baseline that they may have never had access to healthcare, and they may not know, they may not be able to articulate what something is that they're feeling. And I wrote some stuff down. So you got to start at the root cause of a lot of these issues and possibly advocate for someone who doesn't quite understand that their body is currently in trauma due to housing insecurity or unstable housing. And so it may be those basic needs that you need to meet first, like in Maslow's hierarchy of needs. That bottom tier may have not been met yet. So that person is thinking on the level of, I just need some shoes, I need a place to sleep, I need this. And once those basic needs are met, then you can start asking some of those other questions of like, so you mentioned that you've been having a pain in your stomach for some time. Have you ever seen a doctor about that? Or can you describe those pains? And so I think that it's especially necessary to get some of those basic needs met first before we can start asking some of those deeper questions that somebody is not able to think of at that moment. And so we as professionals, as public health professionals or as medical professionals, et cetera, and advocates, we need to be able to meet them where they are. And so as future providers, you also got to do the work yourself, do the homework, look up some of these things that, we have a community health assessment that's coming through Durham for 2020. Look up some of that data and some of that information to help you understand how you can better help other people. And yeah, I think that's about that. That's where I am right now with what I can think of to how to respond to that.
Thank you, Hunter. So we'll go into our final pre-prepared question. This one is for Dr. Wicker, very timely, of course. This reads, when thinking about COVID-19 in the LGBTQ plus community, how has the pandemic disparately impacted this vulnerable patient population?
Oh, in so many ways. And I think in so many unrecognized ways, quite frankly. I have like a list of things that I could bring up. I think that with the pandemic being a virus and the LGBTQ plus community being disproportionately impacted by HIV, access to antiretrovirals was actually reduced. And so some people were left without very needed medications. We've also seen a disproportionate impact on death, on access to care for many of the reasons that have already been spoken about. There's also the homelessness is also connected to this, or being without housing, the lack of resources, lack of testing. People may not be able to get the same needs that were met. One of the biggest things that I noticed was that elective, what was determined to be elective procedures, which I think are arguably, well, I believe they're life-saving procedures, were considered elective. And so people who had gender affirmation procedures, scheduled surgeries, had them delayed. And at the beginning of COVID, and it wasn't universal. I believe that, I know that our OBGYN department, if there was ever a question, it was, so I will give them a shout out because they did say that these are life-saving hysterectomies. These are life-saving bilateral flopping oophorectomies. Like this is a procedure that, and so they did continue throughout doing those procedures. But a lot of them were stopped, and this is something that people have either been saving for, they may have taken out a loan, you know, lots of steps have gone into this, and to just have that ability to become who you are, and in a physically in a way that reflects who you are, taken away in the midst of the pandemic, along with all of the anxiety and depression and loss of jobs that come with this, and that you know, until recently we could all be fired for, as LGBTQ people, for being LGBTQ. And so I think that was something to consider as well. And because people are often rejected by families, which as a healthcare provider or mental health care provider, if you have accepting parents, it can reduce the likelihood of suicide by 22%. If they are rejecting, it increases the likelihood of suicide by 22%. And so that's something that I am always invested in talking to families about, is how to be affirming, and that they have an opportunity to really be a protective factor for their LGBTQ children, or a risk factor. And so we have serious discussions about that. And right now, I think it's harder for some people. The outing and virtual schools is another way that COVID-19 has affected LGBTQ and or specifically trans and non-binary individuals, is because the name a lot of times on the Google teach, I think a lot of people are using, depending on school policy, they might not change it. So then the kid who may be presenting as their affirmed gender, however, they haven't had their name legally changed, they're not allowed to change the name. And so then there is this big advocacy role. In Mecklenburg County, for instance, the school policy in that county is to call the child by the name that they wish to be called. That is school policy, regardless of what the parent wants the child to be called. We do not have that here, or it's school dependent. It's not like a county policy. And so I think there's a lot of room for growth, and there's a lot of unrecognized risks and a lot of it comes, again, there's so many different ways. But I think that the mental health impact of not being able to connect with the community, I actually think the LGBTQ Center of Durham has done a great job of being a hub for connecting, for figuring out how to keep community connection there, as has the Duke CSGD. So that's what I'll say about that.
Thank you so much, Dr. Wicker, for that answer. That was very informative. So we're going to move on now to our, kind of live Q&A portion. You have a couple options here. So you can either raise your hand using the Zoom, you'll click on participants and then raise hand. Alexandria will call on you and you can unmute, you can, turn your video on, leave it off, whatever you want, and ask that way. Also, if you don't feel comfortable asking with your name attached to it in person with your video on, that kind of thing, you can send a message to Alexandria or myself privately using the chat function. I see Alexandria already has a question that's been sent to her, so I'm going to let Alexandria kind of go through these questions, but we will be keeping tabs on, what order people raise their hands, so we will try our best to get to everyone. Thank you so much.
Great. So we're going to start with one question that was sent in through the chat, and then I see that one person has their hand raised, and we'll answer your question next. So this question is, could you speak more on the mental health impacts of COVID-19 on the LGBTQ+ community and on ways in which public health responders could help to address this?
So is this like a question like for
Yeah.
anyone, or is there a specific?
For our panelists, unless the question specifically addresses one of you, you guys can just go ahead and unmute as you have a desire to talk.
Okay, so I've noticed, especially in COVID, is that when it comes to community, that's been really hard. That's been a very difficult issue that's come up with COVID-19, is that missing community. And we have support groups that are available and Zoom meetings, but there's something very special and unique that comes with being able to be in community with your people and with those people that see you and validate you, and vice versa. And I know that mental health wise, it's also, there's been increased rates of depression, and I'd imagine in like in other special groups, addictive behaviors. Addiction is kind of, unfortunately, one of those things that's going to pop up when we're in these sorts of situations. But yes, LGBTQ+ folk are disproportionately being affected by mental health concerns during COVID-19 due to maybe a lack of access to care, including therapists who are affirming of that person's identity, as well as in their probably that look like you. Like, I'm very fortunate that during all of this, I was able to find a therapist who is a queer Black femme, And for me, that took years to find. And so it may be hard for some folks to be able to access those kinds of life-saving services due to finances or due to a lack of resources or availability of said folks in the community who are willing to provide said hours of free service.
I agree with everything Hunter said, and the pandemic itself, I think, has also increased the demand for mental health care services across the board. And so providers are even more full now than they were. So there's even less access to mental health overall. And even the people who really probably are most at risk. And I think one of the big pieces of that is the connection piece that a lot of LGBTQ plus individuals are really have family, the whole idea of like family of choice, especially if you've been rejected by a parent, being away from that family and being away from that social support is really harmful, because if you're discriminated, if you experience some discrimination or like some sort of macro or microaggression against you, one of the best things you can do is talk to other people who may have experienced that. And so that kind of is a way of like taking it out from being internalized and sharing that experience with others. And it's like you're not the problem. It's the person who is discriminating against you is the problem. And I think when people are isolated, there's a lot more risk for people to turn that inward and say, there's a problem with me, because they don't have other people really being able to say, I've had that experience too. That person is, a bigot, I mean, even just something like that is, but really being able to connecting with others to deal with collectively experienced discrimination.
Thank you both. So we have a question from someone that has their hand raised. Asia, you can go ahead.
Thank you so much, and thank you to everyone who made this event possible and the panelists for being here. My question has to do with kind of going to the literature for data that's been collected on the LGBT plus patient population. And oftentimes on the biomedical side or the clinical side, we have data on lab results, outcomes, comorbidities, but it's not being matched to the patient population that we're interested in, right? And I feel like there's kind of like a gap between some of data that's being collected clinically and biomedically and what we're interested in as people focused on health equity. And I guess my question is kind of for anyone, how do we kind of, get this information that we critically need to make the changes we want to see, and what recommendations would we have for someone who's on the clinical or biomedical side of things for their data collection to kind of help us get to where we're going?
So I just want to make sure that I'm hearing your question correctly. You're asking about bridging the gap between the numbers and the data that's available and how to promote said more robust and inclusive data within that research.
Well, for just an example, if I were to go to the literature and I were to search for LGBTQ plus and COVID, I would get a lot of social science data. I would even get a lot of mental health data. I would get a lot of, socioeconomic data. But if if I wanted biomedical data, if I wanted to know what's happening to patients after they come through the hospital and receive treatment, are their treatment outcomes different? What impact is comorbidities having for patients who are maybe living with HIV and suffering COVID? You know, what does this look like? And so when you go to the literature, the biomedical and clinical data, maybe they're not collecting data on, you know, various gender identities or sexuality. So when I go to the literature, I'm not getting the picture. I'm not getting the full view of what it looks like to be an LGBT plus patient who's, you know, suffering with something like COVID. So I just wanted to know from you all what you think we could ask, or what do we say to the clinicians and biomedical scientists that are collecting this data to help them to see, you know, why this is critical and how it can help us.
I think persistence is going to be a big indicator in a lot of this, is that frequently it's hard for LGBTQ plus folk to keep coming back, I guess, in a way. If you really want to show how you can be of assistance and helpful and encouraging, and really wanting not only just that information, but that you care about the overall health outcomes of said persons, persistence is key. You know, stick your neck out and just follow up, because I know sometimes that's hard. I know I struggle with following up sometimes when it comes to talking about my health, because I'm afraid, or because I'm tired, or because I don't want to navigate through that again. I don't want to, you know, I want answers and I want help, but I feel like I'm being thrown around in circles. And so I think that a really big part of this is, you know, one, persistence, but also emphasizing to healthcare providers, maybe from that end, that, you know, we need to start making it more accessible and more affirming places for folks to feel like we value you, we value your input, please keep coming back. And let's see. One of the tips that I really loved was continue promoting to providers to emphasize a sliding scale fee for folks who may not be able to otherwise receive those services. So sometimes we need to really make it a point to have accessibility for folks and to let them know, like, hey, we care, we want you to get this service. This isn't just about a number. But yeah, it can be very difficult sometimes to get that information that isn't anecdotal or qualitative. And so bridging some of those gaps includes making sure that healthcare providers are sticking their neck out, being an accomplice.
Yeah, I can add to that, that we at Duke, at least, there is a if people have, again, this is, you know, thinking about like systemic barriers, if people have access to a phone with internet or a computer, there is a sex and gender form in there with an organ inventory. And my hope and kind of a lot of my work is to drive us forward in using that and implementing that more often, that people could fill out before their appointment, because I think it's a real problem to be that. And so in the position that I'm in, I get to hear about a lot of the problems that happen across our health system, and misgendering, dead naming is a plague. And it is one that keeps people from wanting to come back because it is an invalidation of who they are. Sometimes I've heard about people correcting and saying very directly, my name is blank, I go by these pronouns, and then it's still repeated. And so the other piece of this is that, and reporting, like and I realize that this is a risk, but through we have patient relations. We have, if you have a relationship with a provider, telling them, even better, writing them an email is one of the best things that you can do, because if I have a written email from a patient, I can knock that up to the higher institution level and say, this is a problem, this is medical error, this needs to be addressed. It's harder to do if I don't have like some proof or evidence, and I'll still try, but it doesn't have as big of an impact. And the problem is that if you've been previously mistreated by providers, you're going to be less likely to want or feel safe reporting anything, because then it's like, well, that could damage my care even further. So it's also kind of a catch-22. And one of the things I've been thinking about is, and this may be a question to the other people on the panel or in the audience, but thinking about the value of a patient relations person who is dedicated to the LGBTQ community, or something like that. And so that's something that I've been thinking about.
Great, thank you. So this next question I'm going to start with Simone for, and it is, can you speak more about the progressive efforts you believe can be made by healthcare professionals to reduce bias within both medical practice and academia?
Yeah, so I think it kind of comes back to this big idea of being aware of these biases, and because you can't change them or alter them or make any kind of progress if you're not aware that they're there. And I think a big thing that comes with that is understanding that, of course, there are these, negative assumptions that we can all probably pick out, but there are a lot of probably ones that we might consider neutral or maybe even positive that actually end up being harmful. And so those are ones that are harder to acknowledge with either in yourself or seeing other people doing them. And so I think that's definitely the big first step, is to acknowledge what those issues are. And then in terms of, addressing them, I think another important issue is to understand that you are going to make mistakes, and that's okay. That's kind of how it goes. And so you have to be okay, stepping out and trying to do something and not really being afraid of, oh, it might not be the completely right thing, because in reality, like, no one's going to get there on the first try. And so the important thing is to keep trying and doing that. And so I think those are probably the two most important things.
Thank you, Simone. So we're going to close with this last question from our chat here. And it says, I'm a part of a postdoc program at BCM, and my learning community group was assigned a research project on the impacts of COVID-19 on the LGBTQ plus community. We will be presenting our research in a month or so. Do you have any advice on how we can use this opportunity to make sure the information is received, or how we can make sure that our research actually makes a difference?
Well, to whom are they presenting the information?
I do not have that. This question came from Rana. Rana, if you want to share more information about your presentation to the group.
Hi everyone. We'll be presenting to the faculty members at Baylor College of Medicine. And I believe that our research will also be used in a a bigger research project. So it'll probably reach a wider audience of medical professionals.
And I just want to make sure, sorry, I always, my memory is quite foggy. And the question was, how do y'all make sure that it's being utilized in the most effective way possible?
Yes, ma'am.
Okay. I think this goes back to something that Simone had mentioned with intentionality, like the intention of going into this, you know, just encouraging that with the folks to whom you're presenting. Make sure that you're saying this is the intention of this is to, for example, improve the infrastructure of said healthcare facilities, or to improve the efficacy or the way that we treat LGBTQ plus folk going into this. So I think right off the bat, when you go into a presentation or when you go into expressing research findings, to state your goal or to state your intention or your outcome, presenting that information is saying that based on this, we, you know, our goal is X, and holding people accountable to that.
Thank you.
Yeah, also my 2 cents on that question. I think it's, you know, like I shared at the beginning, Alexandria and I work at a research lab, but our jobs focus a little bit more on this community education aspect of our mission. I'm sure, you know, you can reach out to us even, but find places like that, find other groups that you can collaborate with to kind of get that research shared even more broadly. And finding ways to intersect between not just academia, but also actual practices, actual, you know, like people that the research would benefit as well. So I think finding different ways to share your research might be something worth considering. Not that I'm a panelist, but that's my 2 cents. So thank you everyone so much for your wonderful questions. Thank you so much to our panelists for their wonderful answers and taking the time to share with us today. Before we go, we just want to take 2 seconds to share with you an exciting event that we have coming up in January. So in January, we are premiering the Invisible Organ documentary, which covers a really interesting topic involving cervical cancer and a lot of the work that our lab has done to kind of eradicate that and so much more. We'll send you an email after this panel that will have more details about this event, but we want to just ask you to put this on our radar, or on your radar, excuse me. So we'll be doing in January a virtual screening and then a following kind of panel debrief discussion event. So if that sounds like something that's interesting to you, go ahead and mark those dates down. And I just wanted to say thank you again so much to our panelists for taking the time to talk with us today. And thank you so much to everyone that joined this panel for taking an hour out of your day to be with us and learn. And we hope you have a great rest of your evening.
Thank you so much for putting this on. This is wonderful.
Yeah, thank you.
Thanks, everyone.
Thank you all.
Thank you all so much.